Hello, everyone, and welcome to the conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Chris Payne, editor for MS Focus. I'm joined by Randall Shapiro, who will be talking to us about the history of multiple sclerosis. After the presentation, we'll open it up for your questions and comments. Now I'm delighted to introduce our speaker. Dr. Randall Shapiro was born and raised in Minnesota. After graduating from Occidental College in Los Angeles in biology, he graduated from the University of Minnesota Medical School. He trained in internal medicine at Wadsworth VA Medical Center in Los Angeles, and then in neurology at the University of Minnesota. He was the first elected president of the Consortium of MS Centers, an organization he helped to found. He has lectured and written extensively on all topics associated with MS management, nationally and internationally. He retired from private practice in 2009, devoting more time to teaching and consulting on topics related to MS, including serving as president of the Schapiro Multiple Sclerosis Advisory Group. He is best known for his educating and patient management style, often using humor to teach some sensitive topics. Now he lives with his wife, Kathy, in Peoria, Arizona. We're pleased to have him join us to present on this important topic. Randall Shapiro, thank you for being with us, and I'll turn it over to you.
Well, thanks, Chris. You read that almost the way I wrote it. What we established is that I'm an old guy, and I usually say that I'm the old guy in multiple sclerosis. And as Chris said, I actually founded the first comprehensive multiple sclerosis center in the United States in Minneapolis. That center is still there. It's called the Shapiro Center for Multiple Sclerosis, but I'm not there. I live in Peoria, Arizona. I'm an old guy. I want to establish that because when we look at history of multiple sclerosis, I can tell you about it because I kind of lived it. When I was young and in my 30s and 40s, and I started doing multiple sclerosis pretty much full time, people would say, well, how experienced are you? And I'd say, well, I'm about 40 years old. I've had about 40 years of experience with multiple sclerosis. And they'd look at me kind of quizzically and say, well, do you have multiple sclerosis? No, I don't have multiple sclerosis, but my mother did. And so I was raised with multiple sclerosis, and I don't usually talk about it, but I'm going to talk about it a little bit tonight because it has some pertinence to talking about the history. I was there way back when, before most of you were even thought of in terms of life. So we're going to talk about the history of multiple sclerosis, and my first slide says, what a know-it-all. He acts like he's an expert on history. Well, I wouldn't argue with him. He was around when history was happening, and that's just the case with me. I'm the know-it-all here. I'm an expert on the history of multiple sclerosis, but I'm not really. The real expert on history of multiple sclerosis is Jock Murray. And Jock is pictured here, and Jock is alive in Halifax, Nova Scotia, and he was the dean of the Dalhousie University College of Medicine in Halifax, Nova Scotia, and he was the head of the neurology department, and he is a historian, and he wrote the book on the history of multiple sclerosis. And it's a very easy to read, but very lengthy book, that thick, and it tells you every little detail you'd ever want to know. He's a good friend of mine, and I learned the historical facts from Jock and his book. So I want to give him absolute credit to that. And I want to read you this, and I need to, first of all, I need to make this less from me here. I want to read you the definition of multiple sclerosis as adapted from an update, Update 2018. MS is a heterogeneous disorder with variable clinical and pathological features reflecting different pathways to tissue injury, inflammation, demyelination, and axonal degeneration are major pathological mechanisms that cause the clinical manifestations. However, the cause of multiple sclerosis remains unknown. The most widely accepted theory is that MS begins as an inflammatory immune-mediated disorder characterized by autoreactive lymphocytes. Later, the disease is dominated by microglial activation and chronic neurodegeneration. Yeah. That's what the scientists say multiple sclerosis is. I'm trying to get these slides here. I guess I have to put on here. That's what the scientists say multiple sclerosis is adapted by Up to Date in 2018. That's the scientific explanation of multiple sclerosis. That's not really what I want to talk about, and that's why I read it the way I read it. It's not because I've lost my mind here. Multiple sclerosis is not a new modern disease. It's not a new modern. We can make it sound new and modern by talking about autoreactive lymphocytes and talking about the immune system and talking about cytokines and talking about things that really go over everybody's head, but it is not a new modern disease. If you look in the Bible, you can see areas in which you may say, well, this may be describing multiple sclerosis. If you look at Luke chapter 7, verse 22, did I say that better than the president would say it? I think I did. At the very time he cured many people of diseases and afflictions and evil spirits, and he gave sight to many who were blind, and he answered and said to them, go and report to John what you have seen and heard. The blind receive sight, the lame walk, the lepers are cleansed, and the deaf hear, the dead are raised up. And this is really a description which is talking about, obviously, Jesus, but it may be talking about somebody who has multiple sclerosis and has the relapses and remissions that we see with that particular process. I hate being the historian because I lived through the history of the disease, but here I am. I'm going to tell you about Saint Ludwina. And believe it or not, I was not around when she was born in 1380. She was born in Holland. And she had a progressive illness that suggested the diagnosis of multiple sclerosis. Here you see a depiction of Saint Ludwina. You know, she had a relapsing remitting disease that lasted over 37 years. And she was an interesting young woman. She actually was said to take joy from the misery of others. She accepted the misery, accepted the suffering, and thought that she was accepting it for the sins of others. And in this depiction, you see that she fell skating. And in the story that happened, and I understand it's a true story, she broke her ribs at that time. But she was known to have had facial pain. We call that trigeminal neuralgia. And she was blind in one eye from the multiple sclerosis optic neuritis. And Saint Ludwina died in 1433. I wasn't there at the funeral, but she had multiple sclerosis for 37 years when she passed on. And I was not around in 1794 when Augustus d'Este was born. He's a cute little fellow there, isn't he? He was born and he had fluctuating neurologic symptoms. He's an interesting fellow as well. He was the grandson of King George III and the cousin of Queen Victoria. And he was the product of a clandestine marriage, which was annulled, making Augustus illegitimate. So he was an illegitimate child, the grandson of King George III, but he was abandoned by his royal father and had to work it out on his own, so to speak. His eyes and legs were involved. He was a very sensitive person, at least that's what we've been told. And he died in 1848 at the age of 54. Those are the two earliest cases of known multiple sclerosis that we knew, but I was not around in 1838 when Robert Carswell, who was a medical artist, drew the features of multiple sclerosis. He was alive from 1793 to 1857, and you can see in this depiction, he actually drew from the pathological specimens multiple sclerosis. So this is not a new disease. This was a disease that was known way back when, in 1800s. And I was not around in 1868 when the father of neurology and the so-called father of multiple sclerosis, Jean-Martin Charcot, gave 3 very famous lectures in France describing the features of multiple sclerosis. And he named it sclerose en plaques disséminées, or multiple sclerosis, the plaques of multiple sclerosis. Charcot was a very stately man, and he had his sessions with his trainees by quizzing them. And I think he reminds me of my chief in some ways, and probably scared the daylights out of everybody who worked under him. And I was not around in 1891 when the lumbar puncture was developed. I wasn't around then, but boy, I honed that to a fine technique. When I was practicing, I could take a needle from across the room, throw it at the person's back, and it went right into the spinal canal, and then I'd run over and get the spinal fluid. And no, I wasn't quite that way, but yeah, you got very good at doing spinal taps in those years. And I was not around, can you believe that? In 1899, when oligodendrocytes, the cells that make myelin, were described. When I give many of my talks about management of multiple sclerosis, and I'm talking about how multiple sclerosis forms, I talk about the oligodendrocyte. And I always make the statement, if you can say oligodendroglial cell 3 times in a row, you don't have multiple sclerosis. It may not be the case, but these oligo cells are still important, and we still talk about them to this day when we start talking about stem cells and stem cell therapies and things of that nature. I was not around in 1915 when the pathologist James Dawson published a work describing the pathology of the MS plaque. And I mention that today because when we look at the MRI, which we'll talk about later, we talk about certain characteristics. And one of those that's very significant is a sign that we see, which is called the Dawson finger, Dawson fingers. We see that from the middle of the brain looking up at us. And that gives us the idea that this may be multiple sclerosis. So that was 1915. And I was not around in 1933 when we first developed an animal model for multiple sclerosis, experimental allergic encephalomyelitis. Today we call it experimental autoimmune encephalomyelitis. In rats and mice, this animal model was developed. And that's the model in which many of these drugs that we have today were started in. And that's the model in which we look to see how MS can be tested with and worked with without using humans. I was around actually in 1950 when Roy Swank, a neurologist in Portland, Oregon, developed a low-fat diet for individuals with MS. Roy died just a couple of years ago, late in his 90s. That diet is still around. That diet still does not work, but it works for heart disease. But there are a large number of people who want to believe it works and still utilize it in their multiple sclerosis. That was developed in 1950. If it really worked, we wouldn't be doing this lecture right now. But nonetheless, it's historically important. And I was not around I really was around, but I wasn't practicing. Yeah, when the first use of cortisone was used to treat MS in 1951. I was just starting school in that era, starting in kindergarten back then. The first use of cortisone to treat MS. We still use cortisone to treat MS, and we're going to come back to that. And I was alive in 1955 when John Kurtzky defined a disability status scale. And I mention this as being very important because we still use the Kurtzky scale, the expanded disability status scale, in practice and in studies to measure disability. John died just a few years ago. John actually was a personal friend of mine, and you're going to learn as we go on from here that most of the people that were involved in the important things in multiple sclerosis were my personal friends, and most of them have passed on. So it's not so good to be a good friend of mine because you'll see that it may lead to not such a good ending. But I knew John, and he defined that. I was around in 1957 when interferons were first discovered. And you know that beta-seron, Avonex, Rebif are interferons that were first used in the early management of the relapsing forms of multiple sclerosis, the first drugs that actually were able to change the course of multiple sclerosis, but they were invented, or not invented, they were discovered, shall we say, in 1957. Interferons are proteins that the body makes in response to viruses that interfere with virus reproduction and have to do with the immune system. 1957, they were discovered. In 1965, the initial criteria for the diagnosis of MS were described. I'm going to come back to that. In 1970, we started using adrenocorticotropic hormone. Actually, we used it before that, ACTH. We're going to and it still is a management strategy at times. In 1972, Ian McDonald, who was a personal friend of mine, who has passed away, and Halliday showed that the conduction in the central nervous system was blocked along demyelinated nerves, and evoked potentials were discovered. I remember that very well. I was in school at the medical school at the time. Actually, I was training in neurology at the time. And when that occurred, that was a breakthrough because we now had another diagnostic test for multiple sclerosis, evoked potentials. It turned out not to be very specific. It turned out to be fairly general. We still use this test, though, when we need to see silent lesions, silent abnormalities in the nervous system. That was 1972. And in 1977, Larry Jacobs, who ended up being a friend of mine and passing away, unfortunately, was the first neurologist at the University of Buffalo to give interferon in the spinal canal to MS patients and see that there were changes that occurred in the course of their disease. 1977. And McDonald came out with a new diagnostic criteria for MS back then, and we're going to talk about that later. Oral baclofen, Lioresal, was approved to treat spasticity, and I did the long-term safety studies that allowed that to be approved in 1977. I was there in 1981 when the first MRI scan of the brain was performed, and we could see the MRI lesions that were there. I knew Charlie Poser in 1983, and he became a friend of mine, and unfortunately he passed away. But he described different criteria for MS, and we're going to talk about that in a few minutes. In 1990, the Americans for Disability Act was signed into law. And it was in 1993, and 1995, and 1996 that Betaseron, Copaxone, and Rebif were approved. In parts of the country. It was 2002 that Rebif was approved here in the United States. And then that opened up the floodgates, and we got a whole raft of treatments for multiple sclerosis. And we're not going to talk about all of them specifically, but we are going to talk about the philosophy of them in a moment. But just wait a moment here. Just wait a minute. Let me slow down for just a moment. Conventional medicine says take an aspirin. But in absence of tort reform, defensive medicine says get an MRI and a CAT scan. And so we get MRIs and CAT scans. Sylvia Lowry became a personal friend of mine, and she passed away many years ago, but it was in 1946 that she founded the National Multiple Sclerosis Society. Sylvia's brother had multiple sclerosis, and she was very frustrated with the treatment, diagnosis, and treatment that surrounded him in the New York area. So she put an ad in the New York Times saying, does anybody know anything about multiple sclerosis? And that started the fact that nobody knew anything about MS, and she was dedicated to finding a cause and cure for multiple sclerosis. She's not multiple sclerosis. She was an iron lady. She demanded details, and she demanded people to actually do something. And she wanted to find a cause and cure for multiple sclerosis. And the National Multiple Sclerosis Society was born in 1946. We're talking here tonight for the Multiple Sclerosis Foundation, and that's a relatively new organization. It was founded in 1986. It's headquartered in Fort Lauderdale, Florida, and that's MS Focus, the newsletter, the educational programs, the cruises, and the grants that help people with multiple sclerosis and help professionals. Alan Siegeloff has been the executive director since 1999. Alan and his wife Phyllis are good personal friends of mine. I think they've done a fantastic job of taking this foundation and making it into something that we can all be proud of today. Now I want to take you back and work with you a little bit. I want to go back to 1965, and I want you to think about what we knew in 1965 about multiple sclerosis. And I can tell you that it's a good time for me to go back to, because that's really when I began my medical education shortly thereafter. So I'm going to ask you a question. In 1965, the workup for MS, what we did to diagnose MS included all but neurologic examination, spinal fluid, evoked potentials, blood for toxins. In 1965, we did neurologic examinations. We did spinal fluids, but we didn't have the ability to electrically look at the nervous system with evoked potentials to see how it was conducting. And we didn't know the cause of MS, so we actually looked for blood for toxins to see whether people had any toxic problem that might be causing the disease. So what did we actually know in the 1960s? Well, it was in the 1960s that my professor, I call him the father of American neurology. His name was A.B. Baker. And Dr. Baker founded the American Academy of Neurology. And Dr. Baker was a neurologic educator and a brilliant man, and he was the head of the neurology department at the University of Minnesota, and the American Academy of Neurology became the largest neurological organization in the world. And Dr. Baker taught me that diagnosing multiple sclerosis was clinical and really easy. Now, whenever I say that to a group of people, I get groans and I get, oh my God, you have to see 15 people to have diagnosed. Back in the 60s and 70s, when I was just a pup, I can tell you we knew how to diagnose MS back then. There were 3 criteria that Dr. Baker had. He said to diagnose multiple sclerosis, you need somebody who was between the ages of 15 and 55. You needed somebody who had fluctuations of their neurologic symptoms. They had to come and go to some degree. And you need, most importantly, somebody whose neurologic examination showed more than one abnormality, scattered neurological abnormalities on their neurologic examination. If you had those 3 criteria, Dr. Baker said, you had MS 99 times out of 100. Well, it wasn't quite right about that, but almost right about that. The problem was you couldn't diagnose MS with the first attack. You needed to have fluctuations. And you couldn't diagnose MS with a normal neurologic examination. So that often meant that the first attack put people off. But if you knew those criteria, you made the diagnosis. And it was in the 1960s that George Schumacher, a neurologist at the University of Vermont, codified those criteria. And he said, this is how you diagnose multiple sclerosis for studies, but you have to actually rule out anything that may mimic it. And so he threw that in. In 1960s, we could look at the spinal fluid, but it wasn't very helpful. We had treatment. My mother, as I said, had multiple sclerosis, and she was given botulinum toxin, botulism, as a treatment for MS. She had a tremendous fever that came from that. That was the whole idea. And the fever, she wilted. She almost died at that time. I remember that very well. And then the fever abated, and then supposedly she was supposed to get stronger and stronger and stronger. And there's tremendous willingness, and so that often happened. In the 1960s, we didn't know any better. We gave every kind of vitamin IV that you can imagine to people with multiple sclerosis. And it didn't do any good. So now when I hear this vitamin treatment, that vitamin treatment, biotin, this, that, the other, I know this is not going to do any good. We gave it. We gave it. We already did it. It didn't work. And adrenocorticotropic hormone, ACTH, became more popular. And we started giving that to treat people with multiple sclerosis. And that would shorten the acute attack. That's a hormone that the body makes naturally. We gave it in more amounts than the body would make. It's like giving cortisone. So now I want to tell you about a case in the 1960s. And we're going to take this case and we're going to move it all the way to the present and show you how times have changed. So I want you to think about this 30-year-old woman who developed the acute onset, the sudden onset of loss of vision and slight weakness in the left leg. 2 years earlier, she had weakness of the right leg for a couple weeks that spontaneously cleared. In the 1960s, when she came in, we would do a history and examination. We would do an electroencephalogram looking at brain waves because we're looking at whatever we could. That's the test we had available. We would check the spinal fluid, but it was gross. It was pretty gross. And we'd drop her in a hot tub of water. How strange is that? We drop her in a hot tub of water because the heat would make the symptoms of MS worse, like that fever did. It would make the symptoms of MS worse. And then we could do an examination and see how much worse it was. We don't do that anymore. It's kind of gross, isn't it? We would treat her with IV vitamins. Didn't work. We'd give her intramuscular ACTH and she would get better. Now let's move to the 1970s. In the 1970s, the workup for MS included all but the neurologic examination, spinal fluid, evoked potentials, or MRI. Well, in the 1970s, we did the neurologic examination, certainly. And we could evaluate spinal fluid. We did it even better than we did before. And we got those evoked potentials, those electrical tests where you sit in front of the TV screen and look at a checkerboard square flashing back and forth, and you measure the time it takes to get the electricity from the eye to the back of the brain where it's seen. We could measure that, and we could tell we had that, but we didn't have MRIs in the 1970s. So what did we know in the 1970s? Well, in the 1970s, the diagnosis was still clinical. We had that Schumacher criteria. The Baker criteria we reworked as the Schumacher criteria. So we looked at the age, we looked at fluctuations of how people were doing, we looked at their neurologic examination, and we could do a spinal tap now and look for a protein that was abnormal in it, abnormal kind of gamma globulin in the spinal fluid. And we could do evoked potentials to look for abnormalities in the spinal cord and in the brain stem. And we would treat now with intravenous ACTH. And it was, believe it or not, in the 1970s that our clinic was first formed. And that was the beginning of organized neurorehabilitation for multiple sclerosis, because we didn't have specific drugs. My philosophy was to allow people to do as much as they could with what they've got. So we began to rehabilitate people with multiple sclerosis. So let's look at our case in the 1970s. Same 30-year-old woman, same history. What would we do in the 1970s? Well, we did a nuclear brain scan, which would look for strokes. We could do a CAT scan in the 1970s, but that didn't show multiple sclerosis. We could look at the spinal fluid for immunoglobulins. We could do evoked responses. And then we would treat with IV ACTH, and we would give vitamins to give people energy, knowing that they didn't really treat MS, but we hoped that would give them some fatigue treatment. So now we weren't very good in the 1970s, were we? So let's move to the 1980s. In the 1980s, we began to see scientifically approved treatments for multiple sclerosis. So in the 1980s, which of these scientifically approved treatments for MS did they include? Vitamins, high-dose steroids, frequent use of rehabilitation, magnetic therapy? Well, to be honest with you, vitamins didn't work, so they weren't scientifically approved. We gave high-dose steroids, and they were sort of scientifically approved to treat relapses. The use of rehabilitation, frequent use of rehabilitation, was really brought to the forefront at that time, and we didn't do magnetic therapy. So let's look at what we knew in the 1980s. So it was in the 1980s that Charlie Poser, remember I mentioned him earlier, he was a neurologist at Harvard who was a friend of mine and passed away along the way. Charlie Poser said, well, I like that Schumacher criteria, Baker criteria, if you will, but now we have spinal fluid and we have evoked potentials, and so we should be able to use them to make a formal diagnosis of multiple sclerosis. And we called that then the Poser criteria. And it was in the 1980s that we began to do fancy tests with the spinal fluid, and we could see fancy banding in the spinal fluid. The evoked potentials got more sophisticated. And it was in the 1980s that we began to see the MRI come forth. We changed our treatment to high-dose corticosteroids, high-dose Decadron, high-dose methylprednisolone, IV Solumedrol, if you will. And we began to do more and more rehabilitation, and we started looking at the symptomatic management of multiple sclerosis. So let's look at our case. Same person, same woman, 30 years old, fluctuating course of her disease. Now we're in the 1980s. We would do a history and physical, of course. We would look at her spinal fluid, much more sophisticated, and we could do an MRI, and we could see the spots, these white spots that are gross. This is all spinal fluid, white spinal fluid, if you will. But these spots here are spots of multiple sclerosis. We're going to come back to that. Our treatment, we would give IV Solumedrol or intramuscular dexamethasone, and we would give a physical therapy program with some stretching exercises. And still not very good at managing multiple sclerosis. But let's move to the 1990s. And in the 1990s, scientifically approved treatments for multiple sclerosis included bee stings, cobra venom, calcium orotate, or the ABCs of multiple sclerosis. Back in the 1990s, the MS Foundation and some of the other organizations really got onto the bee sting thing, the MSAA, the bee sting thing. That didn't prove to be worth crap. And I never believed that. It never made sense. Cobra venom was popular in Florida. Didn't make any sense, even though 60 Minutes tried to make it make sense. Calcium orotate came from Germany. That was really just a sham. But we got the ABCs of multiple sclerosis: Avonex, beta-seron, and Copaxone in the 1990s. What did we know in the 1990s? Well, the diagnosis was still clinical. The spinal fluid was more elegant. The evoked potentials got even more elegant, but it was the MRI that changed our lives with multiple sclerosis. And you could see here, these white spots in this MRI, the spinal fluid is black. So you can see the white spots very, very clearly. These white spots that were a little bit blurry before were now very, very clearly. And we could give contrast, and we could see the acute new spots that were there, that these are present for a period of 6 weeks, and then they go away. They're new inflammatory abnormalities on this contrast-enhanced MRI. And then we could see the scars. We call them black holes in those MRIs in which the scarring got to be significant. We don't like black holes. These inflammatory spots can go away. Some of these things can go away at times too as the inflammation subsides. These black holes never go away. They're the nerves dead, that we have no nerve transmission. We don't like those. So let's look at what we knew in the 1990s. This was the era of clinical studies, and we started to classify multiple sclerosis back then. We classified it into relapsing remitting, secondary progressive, primary progressive, and progressive relapsing. You know, we had classifications previously for multiple sclerosis. We knew that 80 to 85% of people with MS began their journey with a fluctuating course. We called that relapsing remitting. And we knew that over half of them along the way slowly got worse, and we called that chronic progressive. But people didn't like that classification. It wasn't specific enough. And so it was in the 1990s that we said that those people who were fluctuating and then slowly got worse, half of them, we just changed their name to secondary progressive. We knew that 10% of people with MS got worse from the get-go, so we called that primary progressive. And 5% didn't read the book. They started out progressive and then began to relapse. We called that progressive relapsing multiple sclerosis. We've modernized that classification now. It's not the same quite, but we began doing this to do research for people with multiple sclerosis, so that we were actually looking at populations of people who look somewhat similar in the clinical trials. Before, we were studying people who are ambulatory next to people who are bedridden in the same pot. Now we looked at relapsing multiple sclerosis, and we did randomized, double-blind, placebo-controlled clinical trials. Really important, randomized. People didn't know where they were getting their real stuff or some phony stuff. The placebo looked real. And they didn't know it, and the investigators didn't know it. It was all coded because we learned that the placebo effect in multiple sclerosis is 65%. No matter what we do for somebody with MS, 65% of the time, they will get better. They'll actually get better. With vitamins or vitamin water or whatever, they'll get better for a while. So we got crazy treatments. We got the bee stings. We got the cobra venom. We got the mercury amalgam removal. We got pregnant cow's milk. We got all kinds of crazy treatments for multiple sclerosis that got very popular for a while. But we learned that we had to do these studies to know what was real and what wasn't. You had to do better than placebo. So the statisticians got involved. And they told us how many patients needed to be in each study to get a clinically significant result. And when we started getting drugs, we had to compare them with each other, and we started doing head-to-head trials. That was in the 1990s. The treatment in the 1990s, we were using high-dose corticosteroids. We got much more sophisticated with our neurorehabilitation. We got much better at symptom management. And I wrote a book, Managing the Symptoms of Multiple Sclerosis, which has been updated 6 times. It's in its 6th edition as the years went by. And we started looking at the immune system as being the real problem in MS. And we realized it was an overactive immune system. So we started looking at using cancer chemotherapies to suppress the immune system in the 1990s. And we got the interferons and glutaminyl acetate that affected the immune system in a different way. So let's look at our case now in the 1990s. We would do a history and physical. We would do an MRI. Sometimes we did spinal fluid, but no, it wasn't as important. We had the MRI. We could see what was going on. And our management included high-dose steroids for acute attacks, beta-seron and Copaxone, if you will, and Avonex, and then Rebif as management for trying to prevent attacks, as preventive managements to modulate the immune system. We got much more sophisticated with our education. I was doing talks all over the world. And we did a lot of symptom management, including neurorehabilitation. So as we moved into the 2000s, the approved treatment for multiple sclerosis included FTY 73057882, Avonex, beta-seron, Rebif, Copaxone, Tysabri, Novantrone, IVIG, plasma exchange, all of the above. Well, really in the 2000s, we got Avonex, beta-seron, Rebif, Copaxone, Tysabri, and Novantrone. What did we know as the millennia changed? Well, the diagnosis was still clinical, but Ian McDonald, that friend of mine who passed away, got very interested in MRIs, and he began to look at MRIs and say, listen, we can see by using certain criteria who has MS by looking at their MRI. It wasn't foolproof, but he developed the McDonald criteria that has evolved a number of times over the years. So we can look at an MRI and give us some really good indication that this person may have MS. The spinal fluid became more elegant. That MRI was amazing, but it didn't correlate with how people were doing. Sometimes the MRI looked terrible, people looked good. Sometimes people looked terrible and the MRI looked good, but it was a good diagnostic tool for us. And we entered the era of evidence-based medicine. We needed evidence to feel good about our thought process in medicine, and we're still in that era. We got the interferons, we got glutaminyl acetate, we got more aggressive immune treatments, Novantrone and Tysabri. So let's look at our case in the 2000s. We would do a history and physical, we would do an MRI, and then we got a visual test that looked at retinal fiber layers called OCT. We might do that. We might look at the CSF. Our management consisted of high-dose steroids for the acute attacks, maybe Copaxone, beta interferon, education, symptom management. We looked at doing things to the immune system we never thought of doing before, such as exchanging plasma or giving intravenous immunoglobulin when the steroids didn't work. And then we would go after those aggressive cases of multiple sclerosis with chemotherapy, mitoxantrone, and with immune suppressing drugs, natalizumab or Tysabri. What did we know as we moved into 2010 to the present? Well, the diagnosis still is clinical. We still use the Baker-Schumacher criteria, but the McDonald criteria using the MRIs have gone through several iterations, so nobody would be diagnosed without an MRI and applying that criteria. The spinal fluid got much more elegant. That MRI is amazing. We started measuring the brain mass and talking about its shrinking, and we got lots of minutia associated with the MRI. And the medications just came forward like you wouldn't believe. And our knowledge of the immune system grew day by day, and the disease MS changed. The actual disease of multiple sclerosis changed. So I want you to take a step back now in the past few years, and I want you to think about back in the 1990s, before we had any drugs for multiple sclerosis. If I were to ask you all out there, how many of you wanted to be in a clinical study with a new drug for MS, but to be in that study, you had to have MS, that's for sure. You had to have the fluctuating kind of MS, relapsing, remitting MS. And you can't have been on any other medication for multiple sclerosis. Well, there were no medications for multiple sclerosis, so all of you would have raised your hand. But if I ask you today, how many of you want to be in a clinical study for MS? But to be in the study, you have to have MS. And you have to have the relapsing remitting MS if that's what I'm studying. And you can't have been on any other medication for multiple sclerosis. How many of you would raise your hand? Probably none of you, because we have all of these medicines that we're treating people with. So we couldn't do randomized, double-blind, placebo-controlled clinical trials the same way we did before. We had to look for patients who were newly diagnosed or patients who just refused to have been on medication. That's a different population of people. It's much easier to treat people who are newly diagnosed than people who have had MS for a while. Much, much easier in terms of suppressing their immune system. So we look at these drugs and we can try to compare them, and we can't compare them because the population of patients is different. And when we did the studies before, my center could supply all the patients for the clinical studies that they needed. But today, to get these patients who fit the clinical criteria, we have to go to hundreds of clinical centers, not only in the United States, but all over the world. And are they all the same? Are these patients all treated the same? Are the populations all the same? When we mix them together, is it all the same? Not likely all the same. And the criteria for diagnosing multiple sclerosis changed from this being the Schumacher criteria. You just looked at the person and took a history and did a physical, to the Poser criteria, where we added evoked potentials and spinal fluid, to now the McDonald criteria. And so we diagnosed multiple sclerosis earlier and earlier and earlier as we got more sophisticated. So the patients that were available to studies were earlier and earlier as well. And I talked about how we had to have more and more centers. And what that meant was that the annualized relapse rate, the number of relapses a person had in the placebo group today, was much less than much less than in previous years, because we have a different disease earlier and we treat it more aggressively. So the relapse rates in all of the studies decreased, even in the placebo group. Amazing how the placebos got better as the years got by. They didn't. It was the MS disease has changed. So when we think about the same drug given in different clinical trials, it actually gives different results depending on when that trial was accomplished. And we got all of these medications, and I know you can't read them. That's why I put it up this way, because we got a large number of medications in the 2010s, if you will, that we have to choose from to try to find the right drug for the right person with the right disease. But what they all have in common is that they're all drugs that affect the immune system. Every one of them knocks the immune system down somewhere different in the immune system cascade, but they're all immune system drugs. So let's look at our case today. We do a history and physical, we do an MRI, yeah, we may do a spinal fluid, probably not. We would treat acute attacks with high-dose steroids. We have the old drugs, we educate, we treat symptoms, but we have a large number of medications to choose from. Some are more potent than others. Now, most neurologists say some are more efficacious than others. I don't like that term, because if you're on the right drug, it may be an old drug. It may be beta-seron or Rebif or Copaxone. If it's working for you, it's as efficacious as the new drugs that are stronger. But we have drugs to choose from, and we want to find the right drug for the right person at the right time. My, how things have changed. So let me show you Sylvia Lowry here. She died in 2001. as I say, she became a really fairly close personal friend of mine over the years. We didn't agree about a lot of things. She really wanted to find a cause and cure for MS, and I did too, but I was really quite concerned about treating people who had MS as well, not just finding a cause and cure. Sylvia would be very proud of what happened, but we still don't know the cause, and we still have no cure. So if it taught me one thing in dealing with the history of MS, it's we have a long way to go. History teaches us many things, but foremost, two of the greatest qualities to have in life are patience and wisdom. And I'll let you look at that slide a little bit to get the real picture of that. And now I am going to see what I can do here to see if I can see people as I take this away.
We have time for a few questions.
Yeah.
If you have a question or comment, please use the raise hand feature in the app. Click the screen to pull up the menu, select more, the icon with 3 dots, and click raise hand. You may also receive an unmute request. If so, please accept. If for some reason we can't get your voice online, you can send a question through the chat function. If you do, please address it to everyone.
I'm trying to see how I can see the raise hand thing.
Well, tell you what, let me get us started here.
Yeah, you pick the questions there. That would be good.
Actually, I have a question. While we have neither a cause nor a cure, what are some of the other gaps the history of MS shows us?
Well, you don't know your gaps until you fill them in. The reality is that we've learned a large amount about multiple sclerosis, the pathology and the physiology of it, but we still haven't got that missing link, if you will, that really allows us to kill it, if you will, to kill the disease. We've learned that the immune system can be modulated in many different ways. We can modulate it with these drugs. We can modulate it. We did a study with total lymphoid irradiation, irradiating it. Is another way to do it. We can actually remove the immune cells. We did that, called lymphocytophoresis. And we can do it with the chemotherapies that we have available to us. But we're missing what it is that triggered that immune system. So we're missing the gap. There must be an environmental or something that triggers an immune system to go bad. We've learned about the genetics of multiple sclerosis, and we don't know it entirely, but we know that there's a genetic aspect to multiple sclerosis. You don't inherit the disease, but you do inherit the possibility of getting the disease. And now we know 200 gene links of sorts that give somebody that potential to get multiple sclerosis. So we're learning about a lot about it, but we're missing what it is that triggers the disease to occur. And I'm not egocentric enough to think I'm going to see that in my lifetime, because this is not a new disease, as I think I've made that point, and we haven't figured it out up till now. I hope we figured it out, but I'm just not.
We have a question from Carla. Carla, you're on.
Yes, thank you.
Yes, Carla.
2 of your former patients, the twins, Judy Swedenborg and Joyce DuPont, say hello.
Well, thank you. I remember them very well. Yeah, thank
Yes.
you. Give my love to them. Do you have a question?
They the program listening.
Look, fantastic.
I do have.
Go ahead.
We've also, not only do they have MS, but they've been diagnosed with hereditary spastic paraplegia now through
You cut out.
What do you know about that?
Well, first of all, I don't want to talk about individual people, but those are two different diseases, multiple sclerosis and hereditary spastic paraparesis. And,
Yes.
and it's unlikely that they would occur in the same person. So they look a lot like each other, but multiple sclerosis has multiple abnormalities, and hereditary spastic paraparesis usually involves the lower extremities with stiffness and spasticity. Obviously, in MS, you can get stiffness and spasticity in the lower extremities as well.
As a brief reminder, if you have a question or comment, please use the raise hand feature in the app. We have another question. This one is in chat. It's from Judy. Actually, I'm sorry about that. Let's try Lisa. She has a question in chat. She's asking, what about protandem? Supposed to be MS wonder cure.
You know, I'm not familiar with that wonder cure, but I can tell you it's not. Having been involved with this since the Stone Age, I can tell you I've seen every wonder cure come and go. And unless it has a randomized, double-blind, placebo-controlled clinical trial behind it, it is not valid. And so without knowing specifically about this particular one, maybe I know it under a different name of some sort, but I don't know it under this name. I would be very hesitant to think that we have a wonder cure that hasn't been brought forward in the scientific community.
Next question is from Robert. What's the status of MS research regarding the applicability of stem cells?
Well, stem cells are a really interesting topic and have a great deal of potential. So I like to think of stem cells in two different ways, if you will. The first way is that I told you that the cell that makes the myelin in the central nervous system is the oligodendroglial cell. Now, the oligo cell does not like to make myelin, and when the MS disease occurs, there's inflammation of the nerves, and the immune system attacks the myelin and eats it up. And it also eats up some of the oligo cells that occur. The immune system diminishes the number of oligo cells. And as the myelin degenerates, the axons, the nerves themselves, break. And that's what causes our disability. So the thought process in my mind is that if we could slow the demyelination process, and if we could get these oligo cells to make myelin and reproduce the myelin and cure and remyelinate those demyelinated nerve cells, we would have a really good treatment to make people better. Now, once that axon breaks, making myelin is of no value. So we need to preserve those axons. But before it breaks, if we could get those oligo cells to turn into cells that actually like to make myelin again, we would have a successful treatment. So we need to be able to take a cell and turn it into an oligo cell, because we only have so many oligo cells in our body. So we need to make more. So stem cells have that ability, but not all stem cells. Most stem cells in our body have already decided what they're going to be in life. So there are hematopoietic stem cells that make our blood forming cells. Most of our stem cells come from that. Some stem cells will be directed to make a kidney. Some will be directed to make liver. Some directed to make a pancreas. They're mature stem cells. So we need young stem cells. And in the old days, that was embryonic stem cells, and that got into a whole political religious problem. But today we have learned to be able to take other stem cells that aren't in that political problem and direct them and make them into oligo cells. So maybe we could potentially in the future, this is really in the future, probably not in my lifetime, direct stem cells that we can direct to make them into oligo cells and turn them loose in the central nervous system and potentially allow them to remyelinate the nervous system. Now, this actually can be done in some of the animal models that we talked about for MS. And so we're beginning to have some hope that this may be the future. But that's the future, and that's not what people are typically talking about when they're talking about stem cells these days. So that's the remyelinating stem cell. Now I want you to think about this immune system that has gone haywire. And we have these drugs to try to regulate the immune system. And most of the time they do a pretty darn good job. And that's just in the past decade, we began to learn how to use them more and more. And we do a pretty darn good job of finding the right drug and getting it to regulate, for the most part, the immune system. But every now and again, it doesn't work. And we go through drugs of various sorts, and either there are side effects or there are issues associated with them, and they don't work. And we think to ourselves, gosh, that immune system is really faulty. What if we could get a new immune system? Our immune system comes from our stem cells, or from our bone marrow, from our stem cells. So what if we got rid of this, the immune system attackers, these hematologic attackers, if you will, from the blood, got rid of them. So we take somebody and we radiate them and we give them chemotherapy and we do all kinds of things like we would do in a cancer patient potentially. And that person would die because they don't have an immune system. So we would ideally like to have a transplant of that immune system from a donor who has the same kind of immune system. They're hard to find, so that's not very practical in most cases. But what if we took some stem cells from the bone marrow? These stem cells are really kind of faulty stem cells. They're the ones that created our bad immune system in the first place, but we take these stem cells and we take them out of the body and we clean them up in the laboratory as best as we can, and we store them. And then we wipe out the person's immune system. And then we give them back these stem cells that are all cleaned up and do a stem cell transplant with their own stem cells, autologous stem cells, back into them and reestablish their immune system. So this is being done, and it's being done in a number of different centers at the University of Washington, at Northwestern, at Harvard, at MIT, and in Canada. They've done some beautiful studies on these types of things. Now, it's not so simple, is it? It doesn't sound simple, and it really isn't simple. So the fact of the matter is, historically, this is something that we reserve for people who need to have it, not for the everyday. But it does seem to slow these very resistant MS situations, slow the attack down, at least for a good long length of time. Now we're beginning to do this reconstitution, if you will, of the immune system by some drugs that are becoming available as well, where they wipe out certain parts of the immune system that then reestablishes themselves with new cells without having to go through all the stem cell transplantation. That's the principle behind some of the newer drugs that are coming out. So I am excited about the future, and I hope that I'm around to see some of that. I don't think I'm going to be around to see the reconstitution of the immune system to make a new immune system, a new nervous system with remyelinating the loss of myelinated nerves, but I am seeing new immune systems in people.
Robert has a follow-up question. Is stem cell research more promising for relapsing remitting or primary progressive?
Well, you know, I don't really like these classifications. They were designed, to be honest with you, to put people into research studies who looked somewhat the same. And I can't tell you the number of people that have come up to me at conferences and things. Obviously, when I make the diagnosis, it's absolutely appropriate and right on. But maybe, and of course, joking. But when some neurologist has said, "Oh, you have primary progressive," and I'm sitting there talking to the person, and I say, "Well, tell me about yourself." And they say, "Well, you know, I had an attack back when I was 18, and it went away, and then I've gotten another in my 30s. It slowly got worse." Well, they're not primary progressive. That's relapsing, remitting, and secondary by the classification. So these classifications are a bit artificial. the drugs that are approved for primary progressive MS were lucky. They were lucky because they had a population of people who were early in the disease and probably would be called relapsing if we watched them long enough. But they got lucky and it slowed the disease down. So I'm not so pessimistic about that kind of MS versus that kind of MS after we get the drugs. Right now we're hampered by insurance companies and things in using these drugs, but it's gotten better. The drugs that were approved for relapsing MS are now approved for relapsing forms of MS. And secondary progressive MS also has relapses sometimes associated with it. So we use them in those drugs. And the same with primary progressive MS. So I think stem cells may become of value there, but they have to be studied in that particular group before they'd be approved for use. We're not in that situation yet.
We have a question from Michelle. What about the hormone Estriol research at UCLA?
Yeah, well, I'm very familiar with the research there at UCLA. Those are good people. I know them. You know, and the background of this starts out with the idea that in the old days, and I'm glad you raised this because it's a good historical question, which I actually should put into my talk. But in the old days, we used to think that pregnancy made MS worse. And it wasn't until the last couple of decades that we actually changed it and said pregnancy actually helped women with MS. And the reason we thought that pregnancy made MS worse is that we saw women who were pregnant and then delivered their child and then acutely got worse thereafter. We all saw that. That's what happened to my mother, by the way. And that's how she was diagnosed. When I was born, right after I was born, she got worse. And so everybody thought pregnancy made MS worse. And then you know what happened? It actually was studied. And when it was studied, we discovered that during the pregnancy, women with MS actually did better. They did better. They had fewer attacks and fewer problems. And then in the 6 weeks to 6 months following the delivery, they had more problems. That's what we had always seen. And so then it got to be, well, why did these women do better when they were pregnant and then do worse after they delivered? And so some investigators at UCLA in particular started looking at the hormone of pregnancy called estriol. You know, estrogens are common in women. I mean, that's the hormone of women, estrogens. Men have estrogens as well, but the proportion is different. But that's estradiol. This is estriol. And so they saw that estriol goes up and then estriol goes down, and maybe it's the estriol that is causing this improvement. They're still doing that research, but the research actually didn't turn out to be quite the way they expected it to be. It hasn't really shown the results that I would like to see to really feel that estriol is really important in this process. But to some people, it is important. So why do I think people got better and got worse? Well, the reason I think they got better is that when they got pregnant, they had an immune system that had half of a foreign body presented to it. You know, that baby is half of the mother and half of the father, if you will. And the immune system comes from both. And it's sitting in the mother. And if the mother's immune system didn't turn itself down automatically the way we're made, if it didn't turn it down, we would have a miscarriage. And so automatically the immune system turns itself down during pregnancy. The person delivers, but unfortunately after they deliver, there's a rebound of that immune system that occurs. And when that rebound occurred, there was the attack of multiple sclerosis became more possible. So we have those two theories. There may be combinations, permutations of both. I'm not going to say that the UCLA theory is wrong. I just don't think it's held up as well as I'd like it to have held up over the years.
Our last question goes to Dolores. I listened to a webinar last week, and the MS nurse mentioned that if your MS is quiet, silent after 50, you might consider not taking any DMT.
Well, that's another good question. and obviously I have views on everything. 50 is a little young for us to say that. And I can say that being in my 70s, I can tell you 50 is really young. But no. The immune system as we age, and I gave a talk on aging in MS for the consortium of MS centers just a couple weeks ago. And what I said in that talk is that the immune system in all of us, as we age, gets less active. That's part of the reason why COVID-19 is such a problem for the older folk. Their immune systems are not as active. We call that immunosenescence. Immunosenescence. That makes us old folks more likely to get infections of various sorts. Makes our lives more fragile. That's the bad news. But the good news is that as that immune system ages, this is Randy Shapiro's thought process, if you will, as that immunosenescence sets in, it becomes less likely also to attack the nerves. That pregnant situation and an older situation, the immune system just doesn't have enough power, if you will, to stay active in many people as they get into their 60s. 50 is too young. We're still diagnosing people aged 55 and saying that's perfectly typical. But as you get into your 60s, that immune system may be having some quietness to it, immunosenescence. It has the bad side, but it has the good side. So that might mean that some people, as they get into their 60s, don't need to be on these drugs. Now, I can tell you before we had these drugs, that people in their 60s, their MS stabilized often. It often stabilized. So when these people who were progressive, they were called progressive MS, and I saw them when they're 60, when they're 70, when they're 80, I took care of these people, and their MS was stable as a rock. Could they walk as well? No, you don't. You got older, you got arthritis, and your nervous system doesn't have the reserve it had before. So the aging nervous system is problematic in itself, but it wasn't MS that was causing the problem. So when we see somebody who is stable, and I mean stable in terms of their relapse rate, in terms of their MRI, and in terms of their neurologic examination, I think to have that conversation, can I be off of the medicine? Is it worth the risk or benefit? Is something that you should have with your personal physician. And I can tell you that before I retired, I took 20 people who were in that category, who were stable on immune drugs, and we discussed it very fully, and they wanted to come off, and so we took them off. And I can tell you that in 6 months, 80% were back on their medicines, not because they got worse, because none of them had gotten worse, but because they liked to have the comfort of knowing they were doing something to protect themselves. So it's a very complicated topic. It's not just simple immunology. There's a lot of psychology that comes into play in this discussion as well. But it's potentially possible to have that conversation reasonably when you get into your 60s, not 50s, in your 60s, when you're stable, rock solid stable.
And that's all the time we have for now. If you missed any part of this teleconference, it will be replayed on msfocusradio.org and available on demand on our MS Focus SoundCloud page or our YouTube page. Remember to follow MS Focus on Facebook, Twitter, and Instagram for times and access information. Our next teleconference will be Tuesday, June 23rd at 8 p.m. Eastern, 7 p.m. Central, 6 p.m. Mountain, and 5 p.m. Pacific. Our speaker will be Dr. Annette Okai. Her topic will be fighting fatigue. Be sure to be here with us for that. We'd like to extend our sincerest thanks to all of our attendees and for your participation, and especially for our guest this evening, Randall Shapiro. Thank you so much for the time you've spent to prepare and share this information with us.
Well, it's my pleasure, Chris. And let me just wish everybody to stay safe, wear your mask when you're out, wear your mask, 6 feet, and let's conquer this virus, because we're all eligible to get it, no matter how old we are or where we are.